Upper cross syndrome, myofascial restrictions in the pectoralis region due to concentrically overloaded muscle. So we're going to start with a fascial spread to engage the tissue. So we're going to take the area that we actually want to stretch, and we're going to anchor our hands on either side. We're going to apply a crossed hand spread just to separate the tissues. We're engaging the fascia, the skin, and the fat only. And for a fascial spread, we're looking for about 90 seconds to release the tissues. And this is an indirect fascial technique. Then we're going to move to a direct fascial technique, and we're going to engage the tissue, the fascia, the skin, and the fat only. And due to the fact that we want to stretch that whole pectoral region, we're going to take our client into a bit of abduction and external rotation. We're going to engage the tissue, and we're going to start a glide from the medial aspect to the lateral aspect of the pectoralis major, moving very, very slowly within our client's pain tolerance. And we're looking for this direct fascial technique to be about 5 seconds or longer. It's a very slow technique, allowing the extensibility in the fascia. This will help to reduce trigger points and increase our joint range of motion. We're going to do this direct fascial technique 2 or 3 times, and we can actively move our client's shoulder into more abduction and external rotation to assist us in this stretch. You should be noting some extensibility and some lengthening of the connective tissue following your technique. How's that? Is that okay for pain? And then thirdly, we can do skin rolling, which can be sensitive to some people, so you want to work within your client's pain tolerance. You're going to pick up the skin, the fascia, and the fat. You're going to anchor your thumbs, and you're going to pull the tissue, lifting it and elevating it as you use your thumbs to move the tissue forward. Keeping the elevation and the lift consistent as you go. And we're going to skin roll through the region. Taking note to where your hand placement is. Care heat hydrotherapy, or you can apply moist heat in this area. Facet joint irritation, upper cross syndrome. So with facet joint irritation on the right side, between C3 and C4, we're going to be using some joint mobilization techniques. So to start with, we're going to landmark our spinous process, coming down to C3. We're going to come laterally off the spinous process about 1 inch to 1.5 inches until we are just on the articulating processes posterior to the transverse processes. We're going to apply a grade 1 distraction of the joints, and then we're going to provide a grade 1 oscillation, which is going to be a low amplitude, high frequency mobilization. And this is an anterior-posterior unilateral vertebral pressure to decrease pain and to increase the movement of the synovial fluid. Oftentimes, A grade 2 oscillation can be more comfortable, so I'm going to change to a grade 2. I'm going to come out, and I'm going to go into a grade 1 distraction, and then I'm going to do a grade 2 oscillation, which is within the physiological barrier only and not into the elastic barrier. Our intent is not to stretch the joint, but to decrease pain and to increase the movement of the synovial fluid. The amplitude is large and the frequency is low. Then we're going to keep our finger in the same location, and we're going to do a transverse vertebral pressure. So our pressure now is going to be to the opposite side. We're going to go into a grade 1 distraction into our restriction, but again, only the physiological barrier. And we can apply a grade 1 oscillation, which is a low amplitude, high frequency joint mobilization. Or we can come out and we can go into a grade 2. Again, into a grade 1 distraction and a grade 2, which is a high amplitude, low frequency oscillation. We would continue this technique for our cervical 4 to treat our facet joint irritations. Trigger points, upper cross syndrome. So now that we've worked the posterior aspect, we're going to work the anterior aspect, looking for trigger points that will often present themselves with upper cross syndrome. These trigger points can be located in the splenius, capitis, and cervicis muscles, the semispinalis muscles, the upper trapezius muscles, and the sternocleidomastoid muscles. So after we have done our neuromuscular techniques to warm the area, we can do a stripping technique coming from the inferior to superior aspect of the cervical spine, looking for trigger points which will present themselves either through a jump sign or recreation of symptoms of the client. We can also go by elevating the occiput and come from superior to inferior, going along the muscle, looking for a jump sign or a recreation of symptoms. Careful to stack your joints so that you don't create load that will impede your work. So once you find a trigger point, you're going to apply direct ischemic compressions onto the trigger point within your client's pain tolerance, waiting for a release or a decrease in symptoms of pain. This can take anywhere from 20 seconds to a minute. Once you have received a decrease in pain or release of the tissue, you're going to flush the area and provide a stretch. If we treat all of the trigger points that we find in this region at the same time, we can move down and continue to the next trigger point, waiting for the release or decrease in symptoms, and again, creating a flush. For the upper trapezius muscle, we can come more laterally towards the acromion process, looking for our trigger point and our jump sign, creating an ischemic compression, working within our client's pain tolerance, waiting for release of symptoms and pain, and continue to flush the area. Following these particular trigger points, we can then enact a stretch by taking your client's head, supporting the base of the occiput, taking them into a full flex position, thereby stretching semispinalis capitis, and just relaxing that slightly, holding that stretch for 30 seconds, taking a stretch for the splenius muscles, both capitis and cervicis, taking them into a bit of flexion and rotation to the opposite side. And then for the upper trap, we're going to take the head and neck, going to laterally flex it to the opposite side, we're going to rotate it to the same side. And again, we're going to take it into a flex position, anchoring onto the acromion to provide more of a stretch for the upper trapezius fibers. Then we're going to work on the sternocleidomastoid, looking for trigger points. Again, after our neuromuscular techniques have warmed the area well, we are going to strum along the tissue, looking for a trigger point, which is going to be indicated by a jump sign or a recreation of symptoms. Another way to access this is by taking your client and putting them into a slight bit of flexion, relaxing them slightly, and coming in with a pincer grasp, using this area of your finger and your thumb, and pinch it gently, making sure to elevate it off of the tissues below so as not to compress on the carotid artery. And you're going to just gently strum up, again looking for that trigger point, which is a recreation of symptoms or a jump sign. Once you've located the trigger point, you're going to apply ischemic compressions for anywhere from 20 seconds to a minute until you feel a decrease in the trigger point or there's a reduction in pain. You're going to flush the area. And you're going to stretch. Laterally flexing, rotating to the same side with full extension and applying a little bit of stretch using your palmar surface to create the stretch, holding that stretch for 30 seconds. Trigger point, rhomboids, upper cross. So after we've performed our neuromuscular techniques and we've warmed up the tissue, we're going to move along the medial border of the scapula looking for our trigger point, which would be indicated through a jump sign or a recreation of symptoms. And when you find that jump sign or recreation of symptoms, you're going to engage the tissue working within the client's pain tolerance until you feel a release of the trigger point or the client indicates a decrease in pain. Once there's been a decrease in pain or release of the tissue, you're going to flush the area, and we want to stretch the rhomboids. So you're going to have your client just come towards the edge of the table, and you're going to take them into adduction to stretch the rhomboids. Following the trigger point release, you're going to use heat to the area, either applying a moist heat pack at this point or later sending your client home with hydro home care.